Force on Aging to order. Today is Tuesday, October 10th, 2023. I'm just going to acknowledge the fact that this would have been my grandmother's birthday. And so as I think about aging, I think about all of the wonderful things that she taught me about aging with grace and the strength of women. Having been born in the late 1800s, she had a wide variety of experience. And one of the things that I loved about my grandmother is that on her first teaching certificate, it said, "Teeth good." So we've come a long way from worrying only about the condition of our teeth as we age and progress. So this conversation today will take us into hopefully the next many decades to come. And so I just want to acknowledge that as we think broadly about what does healthy aging look like in the state of Minnesota. There is a quorum present. One of the first items that we need to do is to approve the minutes from the last meeting. So that would have been the September 12th minutes. Is there any discussion regarding the minutes that are in your packet? Seeing no hands being raised, is there a motion to adopt the minutes?
So moved.
Thank you very much. A motion have been made. Is there any other further discussion? All those in favor of adoption of the minutes, please say aye.
Aye.
Any opposition? The minutes are hereby adopted. Next, we will move on to a presentation by the Minnesota Department of Health. We're excited that you're here with us today and apologize for not being able to get to your presentation at the last meeting.
Good morning, thank you.
Good morning. When you're ready, I'll ask you to please state your name for the record. And then, since there are two of you, if you'll just identify yourselves for the record as you speak so that we go back and forth. And when you're ready, please begin.
Thank you, good morning. My name is Maria Sarabia. I serve as the Assistant Commissioner for the Health Improvement Bureau at the Minnesota Department of Health. Thank you, Madam Chair Cleavorn and Madam Chair Morrison and members of the task force. It's an honor to be here with you this morning, and I'm happy to be here with my trusted colleague and subject matter expertise, Ann Zukowski, who's the Director of the Center for Health Promotion and oversees our aging services. You've asked us here today to speak to the task force for this charge of reviewing state resources for aging Minnesotans, identifying and prioritizing needed supports for people to remain in communities as they age, and to plan for investments to support healthy aging in Minnesota. More specifically, we've been asked to speak to structurally needed changes that address challenges of Minnesota's aging population. We'd also have been asked to explore where not-for-profits and other partners fit in to the MDH position to reach out and help orchestrate private and public partnerships, as well as expand our Rural Health Advisory Committee for older Minnesotans. For these reasons, we've revised our original presentation, and we're here today to address these points. We anticipate speaking for about an hour. We'll talk a little bit about the lifetime or life cycle of well-being and aging. We'll talk about challenges and risk factors, and we'll talk about costs, economic costs as well as social and societal costs that happens when folks are aging and living with chronic conditions, which are preventable. We'll also talk about structural challenges and solutions, and then we're going to close with acknowledging the unique and important role that MDH plays in this important body of work. Let me start by also thanking all of my MDH colleagues here who are here today. We've had folks across the agency contribute to this presentation. Assistant Commissioner Huff from the Health Protection Bureau, Assistant Commissioner Backstrom from Health Systems Bureau, Assistant Commissioner Tura from the Health Equity Bureau, as well as staff and our excellent legislative team. So at MDH, at Minnesota Department of Health, we have a mission of protecting, maintaining, and improving the health of all Minnesotans. Our vision is for health equity in Minnesota where all communities are thriving and all people have what they need to be healthy. Oftentimes, we talk about disease such as COVID, vaccines, or long-term care institutions or various infectious disease when we talk about our aging population and elders. I'll also note that we'll use these terms interchangeably: elders, aging Minnesotans, seniors, and folks who are living over 60 or 65 years old. But our work today is to really focus on prevention. Over the past 5 years, the department has been working hard with community partners, other state agencies, and other stakeholders to bring the public health perspective to aging and make this an agency priority. We will remember where we heard from Mr. Leif Greena from the Minneapolis Regional Retirees Council and Ms. Ann Bussey, a member of the Rural Health Advisory Committee, a month ago, and they really drove home the points of the value, the incredible value that elders and seniors contribute to our society, whether it's in the realms of childcare, volunteerism, civic engagement, creative ways to contribute to the workforce, and also, moreover, invaluable wisdom that we receive from our elders and seniors in our communities and within our family structures. So we need healthy, socially engaged older adults in our communities for vibrant, healthy, and thriving communities. As we invest in important things like long-term care services and supports, we must also really center and prioritize the need for upstream priorities. There are financial and social costs to communities when we do not make those investments upstream and focus on preventative efforts. And that's sort of a way of leading with the intended outcome of illuminating the value of our elders and our seniors and the countless ways in which they contribute to our society and to our families and community. So in public health, we talk about upstream and prevention. What we would like to identify here is that, pardon me, there's a cliff. There's something happening where there's a fracture or a little bit of brokenness that people are experiencing as they age. And if you see in this image, we have folks who are entering into this stream going downhill. What we want folks to, as we age, is have more access, more autonomy, more mobility, connection to family and resources. But if you fall on this cliff, you go downstream into deeper waters, where we call that more so of the deeper end, where you may have interactions as an elder or aging person with institutions and hospitalizations and chronic conditions. In public health, we really focus on trying to be preventative, and we want to create a society, a system, a structure within public health where we prevent folks from falling into the river. We want to bridge folks into aging with grace and with supports to live in communities and with their families. And we need this perspective because it allows for work on the whole range of solutions to address various challenges we face. I'm deeply sorry. Excuse me. So we want folks to have connections, and we want to work towards addressing challenges that we face as a state when we're working with our aging populations and elders. As you know, we're on amidst of a demographic shift, so we need to have more preventative upstream approaches to working with folks who are aging and elders. And this, in our public health realm, there's a need for us to have these approaches for support, and we need a collective, collaborative approach to do this, to be upstream, and this is where the value of the public health lens in our work lies. So we'll start by defining public health. For myself, I've been in this position for about 3 months, but I've had a very interdisciplinary career path and life experience. So when I talk about public health and I talk to my family or my friends or my parents, I say, well, we're really working on the system that helps maintain, protect folks to live their best day to day. And it's these systems that sometimes you don't always see, but that's when you know that they're working, because there's maintenance of health and well-being. The World Health Organization defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. At the department, we focus on people at each stage of life, throughout their life. Even more so, we think about the life course of how people live through their various life stages. And we focus on the interrelationships between people in all of the different life stages. We focus on how folks are part of whole families. And for example, we have elders who may have experience with dementia, but then we also have folks who are aging who are maybe in the sandwich generation and caring for elders. And so the entire life experience and life spectrum, and one can say that we have a strong approach at the final stages of life where we would want folks to have a better life outcome as they age and provide the needed supports. So today, as I've already presented, pardon me, and spoke a little bit about, we're going to talk about health challenges that we face as a state for our aging population and for our elders. We're going to talk about structural and possible solutions, as well as the role, the unique and critical role of the Minnesota Department of Health in working with our communities across the lifespan. And then we'll have space for discussion and commentary. So I'm going to, Ann Zakowski, I'll share with you that, I'm going to share the stage with her, and she's going to go into some specific work for us. And we'll talk about challenges facing Minnesota. Thanks, Ann.
Thank you. Good morning. Happy to be here. We wanted to share with you some of the significant public health challenges that we see facing Minnesota. We are fully aware that the task force knows about these things, but we'd like to shed some light on some nuances to these data that we think are important to pay attention to. I want to say that at the Minnesota Department of Health, we have a small but mighty staff spread across the department addressing aging. And we collaborate closely with the Department of Human Services and with many agencies, with the university and communities to do our work. And this includes working on Falls campaigns, and this is an image from the September Falls campaign put together by Trellis with the cooperation of MDH and the Department of Human Services. So I just want to run through some of the data, and so bear with me while I do this, okay? So first are falls. Declines in physical functioning and mobility are common among older adults and can increase the risk for falls. Falls lead to injuries, but also just ongoing disability. Falls among adults 65 and older are the leading cause of non-fatal injuries in Minnesota and the United States as a whole. The cost of falls was estimated to be around $713 million per year in 2014. Because of population aging, current numbers are even greater. Falls are common among older adults, affecting nearly 3 in 10 Minnesota adults age 65 and plus, and resulting in 48,000 falls-related visits to emergency departments to hospitals each year. This is a story that we really want to change. Falls are preventable. Alzheimer's disease and related dementias. People with dementia have difficulty thinking, remembering, problem-solving, and sometimes speaking. Alzheimer's disease is the most common type of dementia. It is responsible for 60 to 80% of all dementias. Because of underdiagnosis and documentation challenges, we rely on estimates from research studies to determine how many adults in Minnesota are likely living with Alzheimer's disease. In 2020, the number of people was estimated to be about 99,000, and it increases right in 2025 and is expected to double by 2050. What we see is that Minnesota can help improve the aging process to be healthier for our residents. This table lists 5 risk factors deemed by the Lancet Commission as having a well-established evidence base linking them to dementia onset. High blood pressure, diabetes, smoking, lack of physical activity, and isolation all contribute to the onset of dementia. By modifying these risk factors, getting people to engage in physical activity, or by managing them appropriately using lifestyle changes or medications, we can reduce the risk of dementia development or delay its onset. And at a minimum, 1 in every 4 Minnesota adults has at least one of these risk factors that can be modified. This is an important upstream point of intervention. Dementia is also an equity issue. Dementia or unhealthy aging risk factors are more common among certain populations, reflecting unequal distribution of the social determinants of health in our state and country. To address equity related to aging, we need to identify these populations and bring strengths with them in mind, so our strategies achieve better outcomes and have a positive impact on the lives and those who love them. So this page does not list all of the populations, but calls out African American, African born, and American Indian disparities. Whatever data you look at, we are not screening enough for cognitive impairment. If you ask people to report signs of cognitive decline, most have not talked with a provider about it. If we look at claims to see what services are billed for, only 3 in Minnesota adults on Medicare had an annual wellness visit that is designed to promote healthy aging and to screen for cognitive impairment. There is evidence suggesting that screening for cognitive impairment during these visits is not universal and that many providers do not feel prepared to conduct the screening. So when an adult is not screened for dementia, physicians may not catch a modifiable risk factor that could address memory loss, and these adults and their families are not able to plan or be linked with supportive services. Next, I just want to talk about chronic disease. 5 in 6 Minnesotan older adults live with chronic conditions. It impacts quality of life and is related to how much we are socializing and being together. Here is some important data to share with you. Nearly 5 of every 6 adults aged 65 or older are living with at least one of the conditions listed on this slide: arthritis, cardiovascular disease, diabetes, high blood pressure, or high cholesterol. Many are living with multiple conditions. Good management of chronic disease, especially ensuring that people have the tools for good self-management, can improve health and quality of life. Additionally, programs often have a social element and can help address social isolation. So really addressing chronic disease is important. Chronic disease is also an equity issue. We see the effects of chronic disease in adults 35 to 64 years of age here in Minnesota too, and they weigh heavily mostly on our populations of color. So this is a chart, so just if you're watching the colors, this chart is a story of one chronic disease outcome in Minnesota, heart attack-related deaths. So the black horizontal line in the middle of the graph is where every population should be if their rate of heart attack-related death is the same as the state average. So the green bars show the death rated ratio for American Indians, and the blue line shows it for African American or African-born adults. So if you look at those, you'll see that those graphs, those two colors, are way above what we call the horizontal line, which is the state average. So the data are clear for African American, African-born adults, and American Indian adults between 35 and 64 years of age. The rate of death due to heart attack is between 2 and 4.5 times as high as the state average. And that that holds true for diabetes and other conditions. So what we're seeing is that chronic conditions are robbing communities of their elders and of our older adults. A recent article in the Washington Post, which is included in your packets today, talks about this issue. It was also printed in the Star Tribune, and it shows that chronic diseases are responsible for more deaths among 35 to 64-year-olds than opioids and gun violence. We need to pay attention to chronic disease and those who are left out of our discussion about aging because they won't make it to be counted. I just want to also talk about Minnesota caregiver health that needs attention. Caregivers in Minnesota are more likely to be living with at least one chronic condition than adults who do not identify as caregivers. This table displays higher rates of chronic conditions that impact mobility and cardiovascular and metabolic health that also impact physical, social, and emotional aspects of health and well-being. Informal caregiving is very important to Minnesota life, to our families, communities, and at a societal level. So just want to be sure that when we talk about public health and well-being, we're also addressing caregivers. This is another slide that talks about how social and emotional needs also need to be met, and I believe we've talked about this in the past sessions, but I just again want to call your attention to these data. I'm now going to pass it back to Assistant Commissioner Sarabia.
Thank you, Ann. So there's a lack of attention to the well-being of aging Minnesotans in our community, both socially and economically. And we ask ourselves, what does this cost? The answer truly is unquantifiable. We will run through some data points here. In 2022, MDH estimated that chronic disease-related healthcare spending for folks who are 60 or over is $9.3 billion a year. Here's what we do know about these costs. The high healthcare costs are related to chronic diseases. Caregivers hold much of the burden in terms of not having the care compensated or economically valued, and the costs to their future employment due to accommodating caregiving and other out-of-pocket expenses. Oftentimes, employers lose out when tired caregivers show up at work. We're unable to do the hard work at hand, and we all lose the wisdom of our older adults and caregivers in our work and community spaces. And we lose opportunities for mentoring, guidance, and just their presence, and you can't cost that out. Here, we're talking about more so the cost of dementia. The costs are very high. We have examples of these costs where an average annual healthcare spending in Minnesota adults with dementia is substantially higher than the average Minnesota adult. Spending was $38,000 on average for Minnesota adults with dementia in 2018 alone. Most healthcare spending for people with dementia was not directly related to their dementia. Rather, it's related to all the health conditions they are living with and the everyday things that crop up, including managing chronic diseases, as we stated earlier, such as falls. We know nearly 7 out of 10 Minnesotans with dementia diagnoses who have Medicare fee-for-services will live 3 to 4 chronic conditions. We know that Minnesota has one of the highest mortality rates due to falls in the country, and these rates are extremely high in the age groups most affected by Alzheimer's disease and related dementia. Chronic disease-related spending in Minnesota for older adults who are 60 or over was $12,488 per person per year, and that was in 2018. To put the number in context, healthcare spending for all conditions for all Minnesota adults between 18 and 64 years of age was just under $6,000 per year. We're seeing the number of people and the cost of treating these chronic diseases as folks live longer and age and increase in age, and we're projected to double in the expenses and costs associated with that. Here, the increases we talked about on the last slide, they have 2 causes. More adults age who are 60 and over between 2009 and 2018, and this population grew. Over that time period, the rate of prevalence of chronic conditions went up, as shown in this graph. Most people in the 60 up and up age group were living with chronic conditions. These same conditions exist moving forward and drive the 2018 all the way through 2018 projection with a twist. Many adults are also developing chronic disease earlier in life, and we'll be bringing them complications for years to come. So we need to address chronic disease earlier in the lifespan and stop having to pull folks out of that downstream, deeper end connection, needing to go more upstream. Caregivers can also put financial strain on families. When we look at our demographics, we understand that African American, American Indian, Hispanic or Latino, and Asian American caregivers are more likely to experience caregiving related to related expenses, accounting for at least 25% of their income. This is an example of how caregiving can be a social determinant to health and how it interacts with other social determinants like income. Spending such a large portion of one's income in caregiving reduces the ability to plan for retirement, pay your everyday bills, care for personal needs, and it interacts with the baseline lower median incomes among people of color. We're grappling with these extra costs on top of legacies of redlining, other forms of racism, and other barriers that are causing delays in generating generational wealth and accumulating wealth for our families. And here we'll talk about structural challenges and solutions. Thanks, Ann.
Again, we've shared with you a lot of data about health conditions and costs, and I just want to pause and say that these things are preventable, right? We can all age well without memory loss, potentially. There are ways to prevent disease. We can make modifications in our communities and our homes to help prevent falls. We are able to address things like oral health that we'll talk about a little bit more. So again, we at the Minnesota Department of Health are working hard to address these conditions to prevent this. So I just want to walk through some of the efforts that we're making and some calls to action. These slides have a fair amount of text on them, and so I'll just highlight a few things. And I think you probably understand our perspective and where we're coming from, but let me just start with falls prevention. As I've stated before, MDH collaborates closely with DHS and other not-for-profit organizations to work to prevent falls. We do this through campaigns, also promoting programs that have shown to prevent falls, like A Matter of Balance. These programs, evidence-based programs, also demonstrate cost savings. MDH is focused on expanding the availability of these programs to recipients of Medicare and medical assistance, rural Minnesotans, and expanding the number of programs that are culturally responsive and have instructors who represent different cultural communities. The calls to action are that the staffing and amount of funds that are part of the statewide falls prevention campaign efforts operate on a shoestring. There's really, if we want to work on falls, we need to invest more. We would like to see to scale evidence-based programs and promising practices that we've seen through different programs in our state, through the Statewide Health Improvement Partnership, through the Eliminating Health Disparities Initiatives, and Healthy Brain Partnership Grants, where we work with communities who are most familiar with what will work on the ground level. We need to build sustainable reimbursement systems for community-based organizations to offer proven preventive programs via Medicaid, commercial payers, and Medicare. It's important to link people who are in need of these services with programs. We also need to address social determinants of health, such as food security, social isolation, and environmental safety in the home and the community. It's a call for that. Related to Alzheimer's disease and related dementias, MDH receives a small federal grant has created a coalition to address brain health and has developed a 5-year Minnesota Dementia Strategic Plan. This plan builds on recommendations from the 2019 Minnesota Alzheimer's Disease Working Group report commissioned by the legislature, the Minnesota Department of Health Services Aging Plan, and the CDC Healthy Brain Roadmap. So we're trying to build on what we've learned from the past and what's been recommended for our state. Throughout this grant, we are working with primary care organizations, community-based organizations to identify what will work at the clinic level as well as in the community. For example, we plan to work with the Volunteers of America Community Health Worker Program to train hairstylists and barbers to identify signs and symptoms of dementia and educate their communities on risk reduction and community resources. What we need, where our call for action is reaching out to trusted community messengers, that we feel that this is the best way that this information is going to travel and be well received. We're interested in seeing if established local and regional dementia screening and referral programs or centers that link clinics and community supports. Wisconsin has a very strong program in this area. We'd like to engage community health workers to train local community messengers, like I said, and just also begin to just really address gaps in primary care and promote provider continuing education. We've covered chronic disease prevention and management. Again, just to have more concentration on that and expand and scale programs working in those areas. We haven't had the chance to talk a little bit about oral health. The statistics are pretty shocking around the health of our elders' teeth. We know that this impacts their ability to eat well. It impacts how you look and how you feel, and if you want to be with people. There's just, it links to disease and a lot of pain and suffering. We are collecting data on this. The state legislature recently expanded the all payers claims database to include information so we can collect more information about dental claims. We really appreciate that and want to thank you for that. We're implementing age-friendly medical dental integration projects, piloting dental homes in long-term care facilities, and integrating dementia education into dental training programs to sort of train the next generation. Our oral health manager for the state often tells us that we keep the oral health out of the body. We want to integrate oral health into all of health. We're looking for cross-agency collaboration to develop age-friendly dental public health systems, expand training for CHWs, and like I said, expand training for dental students and existing oral health professionals on how to address oral health issues and cover those costs. Caregiver health and well-being. We partner with community-based organizations in the Department of Human Services. We collaborate with the University of Minnesota Center for Healthy Aging and Innovation and the Bold Center of Excellence on Dementia Caregiving. We are partnering with primary care organizations to identify caregivers and refer them to existing resources. I think we need to, the call to action is to scale up culturally responsive community outreach. Again, look at the role of community health workers. Look at offering health programs specifically for caregivers, and collaborate with statewide partners to engage health systems and best practices to support caregivers. So just a few calls for action. We'd love to follow up on anything and provide more resources to the task force, but I'm going to pass it back to Assistant Commissioner Sarabia.
Thank you. So here we just illuminate the critical role for public health. If we talk about the foundations of public health, we're coming to an end to our time here today, but we would be remiss if we didn't elevate how we aim to align and convene and coordinate partners. That's what the call is, private and public partners, to address these challenges and work towards solutions. Also, as Ann has mentioned throughout her comments, empowering and working collaboratively with communities to implement their community-based solutions. Of course, using data and research to guide and inform our actions, and co-identify solutions with communities and elders who are experiencing the aging process, and evaluate and invest in what is working. And these are our core capabilities and responsibilities within public health. In terms of the Rural Health Advisory Committee, their current legislative members, Senate Rob Kupek, Senate Majority, Senator Mark Johnson, Senate Minority, Representative Christy Prusell, House Majority, Representative Joe Schumacher, House Minority, and the committee is of great interest in addressing all the needs of older adults in rural Minnesota and exploring ways to help build our community around them, including environmental changes, to make it easier to be active in communities outside of our homes, opportunities for active engagement with community, including schools and libraries, these community institutions that can play a role to healthy aging, supports to allow aging in place, access to healthcare attuned to the needs of older adults, and reliable transportation is broadly needed, with special considerations for those elders and older adults whose family no longer may live in close proximity to them. The long-term care focus includes both the need to build more stable workforce in long-term care, but also to build community engagement with long-term care facilities. So this is some of the work, as my understanding, of the Rural Health Advisory Committee. And there's an interest in also mentoring and building the pipeline to introduce young people into careers in healthcare, including long-term care, and working specifically with our aging population. In terms of priority areas for the Rural Health Advisory Committee, I would say that It's recently been reframed from long-term care and healthy aging as longevity, and with the intent to broaden how we think about aging in a way that helps us see that it's something that we all strive for, and that it's something that may be a result to we all experience in our lifetime, and it's something that we need all supports for. Longevity is a way to reframe the topic, so it's not solely referring to an isolated sector of the population, but instead the entire lifespan, and it applies to all of us, helping us think of healthy activities and sometimes that aids us in our longevity. And we often discuss aging, and it becomes something of those who have not aged yet, but thinking of it as a collective human experience. So using this frame and developing recommendations that encourage this broader approach is work that's happening. The needs for older adults is to bring their concerns and have the discussions and recommendations that is taking place. And we have varied issues, and there's efforts in a strategic sort of work plan to take on these factors that impact aging and the experience we have as we grow older. As we talk about building awareness of dementia as a risk factor, early detection and diagnosis is important for us, and it's a way in which we empower our communities. The well-being needs is important across cultures, across the state, and across communities. And we cannot assume that it's common knowledge or easily discussed. There are different understandings of dementia and different solutions that need to be tailored at the ground level in communities. This is the same across chronic conditions, but memory loss can be a stigmatizing experience, and there's emotions that are invoked with that. So wanting to ensure that caregivers, not all of us identify as caregivers when we're in that position, and the ideas and attitudes about caregiving look different across different communities and different groups and depending on where folks live. So we find this work, and we need to do more. We need to do more in terms of implementing community-led solutions on this topic. If we talk about implementing our own solutions, there's some things that we're doing through our statewide health improvement partnership. It's a very broad body of work, as well as eliminating health disparities initiative. We have these community solutions grants. We're putting supports in communities. Our call to action is for us to fund our communities to design these very tailored solutions, focusing on chronic diseases and addressing social determinants to health. In terms of our data, we use data. The Department of Health is a very brilliant department with a lot of statisticians, evaluators, and researchers, and we have data, and we use that data, and it's important. We are a critical partner in this body of work. And you can see here about some of the things that we're doing. And one thing that I draw closely to me is I am sort of that sandwich generation. I have elder parents, but telling the story of Minnesotans and experiencing sort of their cognitive changes or decline, and then the story of those caregivers, also compiling and disseminating the data of chronic disease and what those burdens and risk factors are, including dementia. So as we work towards action and calls to action, we want communities to have their local level data to provide aging task force with local communities and community-specific information. And then we want to track progress towards co-developed statewide strategies that need to be tailored within the populations of each community. And again, information is power. Data helps us increase our knowledge and understanding. In the fall of 2022, MDH and the Minnesota Healthy Brain Partnership fielded a survey open to any organization in Minnesota working to address dementia. This includes representatives from organizations across the state, and we're seeking to have action around this matter of dementia that's impacting our elders. And we had over 175 different organizations respond, and we learned that many organizations have invested in supports for people with dementia and their caregivers, reducing the risk of dementia, as well as just unhealthy aging, and improve early detection for diagnosis. Diagnosis is less common across all areas, especially risk reduction. So there's opportunities here to grow our infrastructure and supports, and you can see some of this mapped out in our graph image here. So in terms of our work of just really trying to work and co-identify policy solutions with communities, we're doing things, creative things, I would add, in terms of identifying and implementing reimbursement models for health promotion programs, creating and enhancing local plans and policies, such as creating more walkable space and active living choices, and working towards chronic disease solutions with stakeholders. As we move forward to actions, we are looking for supportive housing options that allow people to age well in their home, and we want to support social engagement to prevent social isolation for people of all ages and abilities. We need caregiver supports, reimbursements for community health worker strategies, and these are just some of the solutions that we're seeking a call to action on. As we evaluate and invest in what's working, you can see a listing here, again, heavy text, but we are consistently evaluating projects. We are convening folks across sectors to address this issue and working towards promoting healthy aging and valuing and honoring our elders. We are trying to streamline various funding models, and we are translating very academic information and very dense data into sort of the plain language public health actions, and trying to increase folks' understanding about what resources or funding is available. And moving forward, we would like more opportunities, more partners, more resources to study public health policy system solutions from across the nation and learn from our neighbors, as well as deeply study what's working in specific locations, some of those very tailored approaches, particularly in rural Minnesota and with specific communities who are experiencing this aging experience in unique ways. We want to elevate and disseminate these partnership models with MDH and in partnership across the state. So as we look at some of our take-home messages, I would reiterate, we must move upstream. That is the cost-effective approach. That is a way in, that is a people-centered approach that honors the life experience and the continuum of one's life journey as we age, so we can be healthy and live as a community. It honors the contributions that elders and seniors make, and we're working towards preventing chronic diseases and other challenges that our elders are experiencing. And the unique role of the Minnesota Department of Health is we are here as critical partners, invaluable partners for innovative solutions for aging in place, for working on locally led solutions, for being that connector to clinical and community approaches in statewide chronic disease prevention and management, and analyzing, disseminating data to guide a collective action and a movement to preserve, honor, and keep our elders and aging population healthy. We are seeking to pardon me, conduct statewide communications campaigns, and would be remiss, of course, we would welcome public and private partnerships to work towards preserving the health and well-being and preventing challenges with our aging population. So I propose to you, task force, Madam Chairs, that please know that MDH is ready to lead. We're here to support and help drive this work. We want to work with fellow state agencies, the other advisory groups, and our communities to promote the health and well-being of our aging population and our elders. And I will pause there and open the floor for questions. We stand for questions and comments and discussion.
Thank you very much. It was a very informative presentation, and we'll go to member questions now. You used the phrase social determinants of health, and I may be incorrect. I think of those as 5 things. Do you want me to say what I think they are, or do you want to tell us what they are so that everyone is on the same page as to what those 5 determinants might be, or if there are more than 5?
Sure. I'll have Ann maybe give the technical answer that we use at the department, and then we can talk a little bit about it conceptually as well.
All right, thank you.
Right. I think social determinants of health, or SDOH, like just becomes jargon that we use every day. So if you step back, there are the conditions that impact how we are able to be healthy in our communities. And so I'm not sure of your 5, but they relate to things like housing, jobs, economic vitality, our built environment, social connection, these conditions that bring us together and allow us to age healthily.
Thank you. I think we're on the same page. So thank you. Members with questions, I'll start with Senator Morrison.
Thank you, Madam Chair, and thank you, Assistant Commissioners, for your presentation. You leave me emboldened, I think, because you present a picture that has so much opportunity. So it's a heavy presentation, but it's also a very hopeful one in my mind. The chair's question about social determinants of health was interesting because I noticed too that you referred to being a caregiver as being a social determinant of health, which is so apt and an important thing to state directly, I think. My question was, if I heard you correctly, was around falls. I think you said that Minnesota has some of the highest rates of fatalities from falls. And I was alarmed to hear that. And I'm wondering if you could elaborate some on that. Does that relate to our weather? Does that relate to our extreme unequal distribution of social determinants of health in our state? If you're able to elaborate, I'd be curious. Thank you.
Thank you, Madam Chair, Committee. I will just say that in my experience, falls is the #1 injury nationally as well. That's what the data shows. And in terms of the specifics of why that is so prevalent in Minnesota, I think we have some hunches, or we have some anecdotal understandings that I guess I'm going to refer to Ann a little bit. And then we likely have really specific data that we could provide when we get that. But I'm going to defer to Ann.
Thank you, Madam Chair and committee members. We don't really know. We've looked at the data by time and over the year, and it's not related to weather that we can see. We have our falls prevention, our falls epidemiologist who's been looking at these data. We know that Minnesota has good reporting that comes from hospitals, so we wonder if that's also a possibility. We know that nationally during COVID, we saw falls rates go up higher, and there's speculations around that as well as of people being less active and then being less strong, and so we're seeing falls in adults. But we can't answer your question in terms of why.
Thank you.
One moment, Dr. Gogler. I have a list. Senator Housley.
Thank you, Madam Chair, and thank you for that presentation. It's a lot of good information and a lot of room for improvement. I just have a couple of questions that I was curious about as you were going through it for the Assistant Commissioner. So the Department of Health Improvement is under the Minnesota Department of Health. How many folks actually work in the Department of Health Improvement?
We have over,
Assistant Commissioner, if you'll just state your name before
my
you answer.
apologies.
for the
Madam
record.
Chair,
Thank
yes.
you.
Madam Chair, Committee, my name is Assistant Commissioner Sarabia. We have over nearly 300 employees within the Bureau, within the division, and the division, there's 2 other divisions within the Bureau. So we have a significant amount of employees, but the folks that we have specifically assigned to our aging work is a smaller and yet mighty team. And I'm going to refer to my director about complement data.
Thanks.
Well, Madam Chair, committee members, so work that we do in aging is spread throughout the agency, right? We're not presenting here today on long-term care or on our infectious disease prevention and COVID prevention work, but within the Division of Health Promotion and Chronic Disease and within the Center for Health Promotion, I believe we have about 4 FTE working on this. It is partial positions of some people, and the funding for this comes from federal funds and a very, very small state amount of money that contributes to that as well, that was awarded to us, to the department, many years ago, I think 15 years ago.
Senator Housley, follow-up.
Thank you, Madam Chair. Yes, that's what I was wondering, because what this task force is tasked with to come up with the report by January 2025, I was wondering how much support can we get from this health improvement division? And so there's just 4 FTEs, I think I heard,
Okay.
in the
thank you.
aging, yeah.
So, Madam Chair and committee members, let me just elaborate a little bit on that. The 4 members are working specifically on dementia and Alzheimer's. We have staff, so in the Center for Health Promotion, we have approximately 40 staff that work on chronic disease prevention and work on programs such as arthritis that tie to falls prevention. So there are staff, and I will say that the center has been working on trying to build its capacity and seek funding to build its capacity in the area of aging for a while now, and have secured federal funds through the BOLD funds, and again, are seeking to really expand and take a lead in this work.
Thank you. Senator Housley.
Okay, thank you, Madam Chair. Just one last question. In the role of the Minnesota Department of Health on that slide, it says you're conducting statewide communication campaigns. I was just wondering, can you give us a couple of examples of what those are?
Thank you. Assistant Commissioner.
Thank you, Madam Chair. Senator, we have examples, I think we've highlighted sort of the Juniper Fall Prevention Campaign. We have other communications that we are standing up around. You want to add that? Pardon me, I'm going to defer to the director.
Thank you.
Madam Chair.
Please proceed.
Madam Chair and committee members, thank you. The legislature awarded us funds in the last session to develop a statewide campaign on dementia and Alzheimer's, and that work is starting now with hiring of staff. So that was just awarded in this last session. I just wanted to thank you and just remind us all about that.
Thank you very much. And we'll move to the next question. Representative Zolnikar.
Thank you, Chair, and thank you for the presentation. And I just wanted to follow up on Senators Morrison's question, because I think it was a good question on falls. And it may be relevant to give a little feedback as a person who spent the last 40 years in nursing homes and assisted livings and as a CNA. And I think it's important for people to realize that 40 years ago, we restrained everyone when they were a fall risk. We medicated people if they had behaviors that were agitating to themselves or others, to the right or wrong. That was best practices as directed by doctors. And we didn't have falls, but we have not changed Alzheimer's disease, dementia disease, Parkinson's, obesity, congestive heart failure, and the list goes on. That reality has not changed. So when I look at this and I look at what's changed in 40 years ago when I was a CNA, I didn't have falls off of a toilet. I didn't have falls from a bed because people were restrained. Now, that happens. If some of them want to be independent and self-transfer, they self-transfer because of the disease. They don't follow the directions as a care plan. A care plan can't be followed 24 hours a day if a person doesn't have the ability to cognitively follow and track. And no facility has one-on-one staffing. No home has 24-hour staffing. If you're a spouse caring for someone, you generally are going to leave the bathroom for a second or leave the person because you have to go use the bathroom yourself. There could be a fall, a fracture. A fracture could lead to a death. A head injury. I've had 3 concussions and multiple surgeries from breast cancer. And so, they have blood clots. They have all the same risk factors. And then you add the other layers of having multiple diseases happening at one time. Most of them don't have dementia and Alzheimer's simply as one category. They also have COPD. They have diabetic conditions, sliding scale. They're overweight. And so the issues that you laid out are accurate and true. And so when you're self-transferring yourself, your risks are higher. And the other thing is, oftentimes a break will happen and a fall a second. We have women living very long and men living very long. We have a very aged population in Minnesota. We lead the way on how old we live. And so even though it's cold here, we seem to have longevity. With that said, you have women with a lot of osteoporosis. So I will be at risk for breaks. I can tell you that right now, having had cancer. We have higher cancer risks right now because more people, it's Breast Cancer Month, did not get screened because we had 2.5 years of a pandemic. So we will have more stage 4, stage 3 cancers, and we will see more falls in the older population and the younger population. The other part that this ties to is the regulations that come from the Minnesota Department of Health. How we regulate can be then, you have to do an intervention. Every time there's a fall, the facilities have to do an intervention. You get run out of interventions because there is no other intervention. We aren't using restraints, medical, physical restraints or chemical restraints. So therefore, it's pool noodles that you cut in half and you try to keep them safe and not roll out of a bed. Alarms, people don't want alarms because that scares people. So we've removed all those things, but the fact is we still have aging people. We're not going to change the disease and the decline, but the expectations are high at a time when we have a very challenged workforce. And so I challenge us to remember that we're going to need economies of scale for the largest chronic care people, where we have high needs, multiple diagnosis, and very high care needs. Because going to everybody's house, as ideal as that would be, when you have a labor shortage, is going to be challenging for them to get quality care. It isn't a home. And I also challenge us to look at what we're going to do as we move through a pandemic, because we need to assure the connectivity happens. Health, to your point of all the indicators, is so much more than physical. We need to have families together. We need to have relationships. The seniors need to see a smile. They need to have people with them when they're dying, and as much as they do as they live their whole life. And we need to make sure we're ready for all that, because we will continue to have viruses. I'm a farm girl. Nature will prevail. And so we need to learn from what we know and be ready, because life has to happen simultaneously with the diseases that we're going to face. But I think the social connectivity, the mental health that you've laid out here, we have depression at all economic states and all physical states, and it's not avoiding seniors. We need to have physical exercise helps the bones, to your point on falls. If we don't exercise and we're not together laughing and seeing a smile, our human demise happens. And so I encourage us to find every way to keep in greater Minnesota and the suburbs and the cities, to keep people together with neighbors. It doesn't mean not being safe. If you're sick, wear a mask. But we have to be together, and we have to be exercising and moving, because we have 6 months of winter coming, and we need to be out. So thank you for the report. I think we have a lot of work to do and a lot of opportunities. But falls have been happening for the entire time I've been here, and we just have a very aging population, and we will expect more.
Thank you, Dr. Gogler.
Thank you so much for that informative presentation. I guess I had a couple thoughts reacting to some of the things you said. Starting with social determinants of health, which I think are really interesting. I pulled up what the 5 were, and they're economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. And I think the way I think about social determinants of health mostly is these are things that actually can be changed and modified. And when we think of public health's role in that, that's to me why the framework is so helpful when thinking what do public health perspectives and actions contribute to healthy aging for Minnesotans. And when you think of something like caregiving, for example, that's an interesting thing. For a long time, I actually was a big advocate saying caregiving is definitely a social determinant of health for reasons X, Y, Z. But in fact, caregiving is something that interacts and intersects with those different social determinants of health. But I don't know if I'd call it its own social determinant of health. I don't think we can change whether someone's a caregiver or not. So that's probably an important way to think about it moving ahead when framing what we'll do and what would be some of the key actions for public health itself. One thing I will say, I understand the perspectives where it seems like in the past 40 years, nothing has changed with dementia. And in some respects, that's true. Current treatments really haven't shown a lot of effectiveness in modifying the disease course of dementia, with potential current exceptions, which, if our task force ever has time, we can maybe talk about those too. But where things have changed significantly, and what I would argue how it has changed in the context of dementia are a couple things. One is in the work related to identifying pathways to prevention. That was not known up until maybe the past decade or so. And if many of you recall, Alzheimer's disease in terms of how it was funded and studied lagged significantly behind other chronic diseases like cancer or heart disease. That changed probably only a decade ago. So a lot of the work that's been emerging in Alzheimer's disease that I would consider more of from a breakthrough perspective has been happening really over the past 20 to 10 years. And in the space beyond of disease-modifying therapies, of prevention, of care models, we know that work. Other innovations, in fact, there's actually pretty strong evidence that, yes, these things do work. Yes, they can help manage symptoms. Yes, they can be helpful, but it gets back to the initial point I made at the first task force meeting. We know the solutions. How can we scale them? Like you were talking, economies of scale. How can you disseminate them effectively to all communities and tailor them so that they can fit and work and also can be sustainable? That, to me, is the key question and issue. And so that is, I keep coming back to this, but it's so important. And for us as a task force, when we think of our final report, I really strongly believe, and it's my own opinion, but I strongly believe that is what the task force should emphasize. Not a summary of, again, this is what this program does, this, we're getting older, those kinds of things. Okay, we know that. But what can we do to continue to advance our innovation in the state of Minnesota? Last point I'll make is when we think of chronic conditions, and I think many departments of health, not just in Minnesota but across the U.S. have done this traditionally, they either, one, believe dementia and Alzheimer's is kind of not really our thing, that's the Aging Service Network. Now that's changed with some of the federal funding like the BOLD Act. But two, I think another key point, and you kind of got at this in your presentation, I would argue Alzheimer's disease is the chronic condition. It is what drives and complicates all the other conditions. And the more that Alzheimer's and dementia is truly elevated as a point of emphasis at state departments of health, the better we can move all together, both in the state and beyond, towards addressing some of these really challenging public health issues related to aging. So, those are the points I wanted to make.
Thank you, Dr. Godler. Members, were there any other questions or comments? Ms. Foley?
I know in your presentation, you mentioned food insecurity and social isolation. I know in the rural areas, that's a big issue, and it's becoming more of an issue in the inner cities with volunteerism falling. The aging population is the largest volunteer population out there. How do we get the younger people involved to do community engagement for like Meals on Wheels and for social isolation to get them going to visit people?
Assistant Commissioner?
Madam Chair, task force members, I agree with much of what has been said here, and as I disclosed earlier, I have a little bit of a multidisciplinary background, and what I will say is what sparks our interest is the innovation. It has to be cross-sector and collaborative, from workforce strategies to post-secondary ed career pathways. I'll say that myself, I'm a big proponent of those programs because I am a product of those programs. I went through different AmeriCorps volunteer programs, helped me pay for college, helped me build my career path. And I think there's opportunities for the health department to be strategic in working with a statewide strategy. We know that we have a really large population of young people, and there's this big, I think it's the graph that kind of gets skinny in the middle and gets big on both ends. We have the aging population living longer. We would be absolutely, we would be very delighted, and we would encourage more cross-collaboration and strategies. I think the weaving in the public health frame and the social determinants of health is the approach we need to take, and it needs to be acknowledged, I think, as we do more collaborative work. I'd also share prior to being in this appointment, I did work in aging and disability services at the county level, and so that's really important. That's where the ground level work happens, and us having that intergovernmental approach with a multi-sector approach is where the innovation, I think, will happen and must happen for us to rise to the calling that this task force has presented. And there's a lot of opportunities, as Director had mentioned, the community health worker. That's a really unique stepping stone, and that could lead to a lot of other career pathways to support health or human services, aging population, caregiver fields of work, and so forth. And so we think that is a very a good start, and we need more investments and more focus and more strategy in that space. Those are my responses for now.
Members, did you have a follow-up? Ms. Foley?
Not really a follow-up on that question, but also with COVID, telehealth medicine became a bigger selling point for a lot of people. It's easier to do and such. But technology and broadband, do all the areas in Minnesota have broadband access now? And I know the older populations, I know my parents aren't real keen on learning how to use some of that technology. How do we get that technology and make them comfortable using it?
Assistant Commissioner, do you have a?
Madam Chair, task force members, one of the things that comes to my mind and that we've talked a little bit is we use the term caregiver, but that's really intergenerational social connection. And if there's a way in which we sort of incentivize those connections so our elders and seniors can utilize and understand the technology more and the resource and the, the benefits of it, that would be an excellent opportunity to explore. In terms of the access across the entire state and within rural, I don't have an answer for that. But we know it's an issue. Your previous comments also were around food access. We also know that that is a challenge. And again, this intersectional, cross-governmental approach is what we need. And we are here to be creative and to come up with long, sustainable solutions.
Thank you. Ms. Foley, any follow-up? Ms. Schneider?
Thank you, Chair. Thank you for your presentation. There are a couple things I'd like to drill down on, and then I have an observation that I'd like to make. On the statewide health improvement partnership, can you give me a little bit more information? I hear about this locally when someone talks about a SHIP grant. Is that what they're talking about? So are these sometimes volunteer-driven, and how do they get funded? That would be one thing I'd like to know. Maybe I could take these in order if one of you would have some response to that question about SHIP grants.
Assistant Commissioner?
Madam Chair, Committee, do you want to speak a little bit more to the historical context of SHIP?
So the statewide health improvement initiative or partnership, SHIP, fund is funded through state funds. The legislature created this program, and I'm going to misstate the date, but it was during when we were looking at healthcare reform in our state. And so it funds all 87 counties through local public health and community health boards to work on the areas of active living, healthy eating, well-being, and prevention of tobacco use. There are staff at the local level collaborating with community leadership teams made up of community members who are guiding the work, and these funds are used to address those issues. At one point in the SHIP legislation, it included a mandate to work on aging issues as well. That language has been removed from the statute, but many communities continue to work in the aging area.
Thank you. Second
Schneider.
question. Go ahead.
No, please, Ms. Schneider.
Oh, thank you. Second question. On your data, I was just wondering, I'm coming kind of from a managed care background and some of my experience in aging, and I wonder, do you have data on any differences in outcomes for aging situations if an individual is receiving care management or care navigation versus the individual who may feel or may actually be that they're sort of on their own with it. I'm just interested in this whole concept of care management and case management, et cetera, et cetera.
Assistant Commissioner?
Madam Chair, task members, I do not have that data on hand, but you're also getting some wheels turning for us, so we could come back and look into some of that data. I think we may have access to look at it in that way in which you've presented it. And could we circle back with you, ma'am?
Ms. Schneider, can you, if I can defer to Dr. Goldberg for just a minute, did you have a comment?
Yes, that's a great question, Maureen. And in fact, there's a good evidence base that suggests that in fact, care management approaches, particularly dementia care management approaches, are very effective. Having a navigator to help a family or person with a chronic condition or say living with dementia navigate through what is often a very fragmented healthcare system has been shown to be an effective service model to the extent where CMS, and actually I think this is a major federal policy breakthrough, but CMS is going to put out a call for application soon to support applicants, primarily healthcare systems, to provide up to 8 years of what's called collaborative dementia care. It's called the GUIDE model. And it's based exactly on the principle you pointed out, Maureen, this idea of care navigation and care management. And what makes it so innovative in the context of dementia, this might be the first Medicare/CMS policy that will provide support not just to the beneficiary, in this case a person living with dementia, but their caregiver as well, whether they're a beneficiary or not. And it's all based on this principle of care navigation, connecting the caregiver and person with dementia, not only to multidisciplinary care within a system, but then also to community-based respite and services. I mean, it's a very exciting model. And when you talk about potential breakthroughs in dementia, this is a big one. On par, I would argue, with any quote-unquote disease-modifying therapy. Now, we'll see in Minnesota how many entities actually apply for it. The RFA is about to come out, request for application, pardon me.
Thank you. I'd like to go back to Ms. Schneider. Did you have an additional question?
Yes, I did. Thank you, Madam
you.
Chair. This is more of an observation. As I mentioned earlier, some of my background in aging comes from my work in managed care. And so managed care providers have been following social determinants of health for years. So I was happy that you brought it to the forefront today because I believe it is part of the backbone of our discussion. And there's just one thing I want to point out. You could take any of the 5 factors, 5 determinants, and you could come up with myriads of perspectives on aging and how they might apply. But the one I want to talk about today is the whole neighborhood and built environment, and particularly housing. What I find more in the rural area, because I'm not as familiar with metro, but in the rural area, we have very many, usually widows, who are living in rather large homes. And they're having trouble in some cases paying their heating bill or their taxes or their upkeep or whatever it is that costs a homeowner on a regular basis. But there is no place for them to go that is senior friendly. And therefore, the housing stock in a given community gets skewed. And so if someone from a younger person or an industry would like to come into a community, well, there's a barrier almost immediately, no housing. However, if we were to be able to help that single person living in that house, and by the way, with winter coming, I want to remind all of us that some of these widows are living in only 2 or 3 rooms of a very large home because that's all they can afford to heat. If they were to be able to go to some more substantially housing that would help them and add to that upstream that you're talking about as opposed to the downstream, then the housing stock also would be freed up for the younger families. And then we begin to have the ability to better address the whole concept of senior isolation, because we get some younger people in who want to volunteer, who want to be interactive and intergenerational. And so although I believe every one of the components of the social determinants of health are important, as I said, the housing one is one that concerns me most. And I think our economic development partners also do need to be in on our discussions. That's all I have, Madam Chair. Thank you.
Thank you, Ms. Schneider. Would you, Assistant Commissioner, do you want to have any comments to anything that you've heard up here today?
Madam Chair, task members, I would say, I think we're in a room of very brilliant folks, and the thoughts and reflections and observations that you're sharing are things that we will be taking back, and that in partnership, I hope that we will. The gems are the intergenerational, the social connection, the CMS approach, like these are systemic, structural, and societal shifts that we have to harness to help us. And I agree with the ideas and the concepts shared here, the observations of being in the field and working in the care arena. And so we are, again, I would just reiterate, we're willing partners. We have information, we have data, we have will. We would love to partner on more resource building and service delivery, but this innovation, we're at a precipice where we need to do something differently, and we have to do it soon.
Thank you. I'll just add my own comments, and I don't know if you'll want to have a comment after or not. So as you were talking about the upstream model and what we're hearing today from our members, we need to start this work much earlier than we currently are. So as I'm looking just at the aging statistics for our state, right? We have this more kindergartners. So really starting upstream is how do we embed healthy aging from preschool forward, right? Healthy eating habits begin early. Education begins early. Wealth management and understanding how wealth works begins early. So as we're looking at aging systems, we can't wait till we're 65 and older and growing to 1.2 million Minnesotans, right? So for me, as we're looking at these social determinants, we have to start at the very beginning so that when we get to the twilight years of our lives, we're already there for how do we do it, and then what assistance do we need, right? And do we have that system, that structure in place to support us as we age? So it's a yes and, right? Both ends of that spectrum we have to look at. To Dr. Gogler, I would say, absolutely, I believe caregiving, this is my opinion, and I'm not the esteemed researcher that you are, but caregiving is such a chronic stressor for our families. And we do know that caregivers often die before the person that they're providing care for. So if we don't look at the caregiver and the needs of the caregiver in this process and embed that into our systems, then, okay, so we have alignment here. Okay, awesome. So I think, yeah, we do have to look at this holistically, as you have said over and over. And I want to thank you for the good work that the Department of Health does. You know, as we are looking at this task force and the work that we need to do together, we have to create that healthy space to challenge what we are doing and to find those opportunities and innovations as we go forward. So with that, do you have any comments to that, or do you want me to just?
Madam Chair, thank you. Task members, thank you for your time. We appreciate the opportunity to present.
I'd like you to kind of sit tight just a little bit as we go through this next part of our agenda. So if you don't mind just staying where you are, we may have questions about what our work will look like going forward as a task force, which is the next part of our agenda. So members, we've heard a lot today, and we know that there's a great deal of research out there. We need to think about our work plan as we go forward for the next 6 months. As we've said, the report will be due in 2025, January, but working backwards, we see that we'd like to have a draft out, fall of 2024. So we have a lot of work to look at, to process, and to figure out how we actually accomplish the goals of our task force, which were outlined in the legislation In your packets today, you're going to find the article that was referenced about chronic health. I encourage everyone to read America's Epidemic of Chronic Illness, Killing Us Too Soon. We also have in our packets today a fact sheet from the Department of Health about Alzheimer's disease and dementia. I would encourage anyone in the public who hasn't looked at those numbers to please look at that. And then we have our legislation, which tells us the things that we need to do, our duties, as we look at how we are building a report that will guide us into the future. So with that, members, I'm just going to kind of ask just kind of a few opening questions to say, what should our work look like going forward? Let me see if I have those questions. Well, maybe I'll just ask you, what is it that you would like to see in our work going forward? What would that look like for you? Members, do you have any comments about that? Yes, Representative Zelnikow.
Thank you, Chair.
Zeleznikar, sorry.
I would challenge us, when I look at the mission of protecting, maintaining, improving the health of all Minnesotans, I think a critical issue that is on all of our minds in every community in the state is the hospital bottleneck of not being able to place unplaceable people in the sense of health needs, mental health needs, behavior needs. A lot of seniors aren't being able to be placed right now. I watch the Hennepin County every week. I was on a task force last week with some members in the audience a couple weeks ago in Duluth with doctors and educators from the colleges and hospital discharge planners and various people looking at what are the issues, and we know what the issues are. And having been on a provider side, I know what the issues are too of why they can't take them. And so I would challenge us to look a little differently and look at I see something that is a pilot project for some sort of an academy that has for high-risk comorbidities, whether it's for youth, whether it's WINGS, where we could do telehealth and insight assistance for people. And I don't have the answer, but I can see the issue that is happening for all Minnesotans. When you can't get the surgeon because they can't get the person into surgery, because we're bottlenecked, the ERs are full, you can't get them placed onto a bed. The outpatient, it's a domino effect everywhere. For outpatient surgery, for trauma surgery, and then for just, we're holding people in hospitals, in the emergency room, on hospital floors. We have kids that have not seen the light of day for a year in hospitals. That's just not okay. We have seniors that are, this is it's not a home. A hospital is not a home. And it's the only place we have to discharge somebody when all of the other wheels have fallen off the bus in society, and they are multiple ones right now. And so I think we're gonna, I would hope that we can address the hospital bottleneck that is definitely, it's seniors and it's adults and it's the entire family unit being affected. That would be my suggestion, that we look at something and some innovation and what that could look like. Because we have resources across the state where we have buildings that are empty that could be retrofitted. And where it is in the state isn't my priority, just that we do something. Because doing nothing is not a solution right now. And I love what you're doing with education on Alzheimer's and dementia and training, all that. I think we have to innovate right now because we know what the issues are. And there are a lot of intelligent people at the state and out in the field. And I think we can find some answers, but I think we need action because this is straining our resources. It's not making people want to go into healthcare when we continue in a vacuum of dysfunction. And I think we need to find some real solutions. And I think we need a pilot project that looks a lot different than what we've done recently. Thank you.
Thank you, Representative Zeleznikar. And I would like to just say, the Department of Health executes. We legislate. That sounds like an opportunity for a good piece of legislation. And there could be some really good exploratory work done around that as well. So, yes, Senator Housley.
Thank you, Madam Chair. I would like, going forward, to really focus on our workforce That is such a huge, huge issue. And just about a month ago, a report came out on the vanishing workforce in the state of Minnesota, and it was done by Presbyterian Homes and Services. Sullivan Cotter is a company that works with healthcare organizations to improve the outcomes through workforce strategies. The Minnesota Business Partnership, a nonpartisan public policy organization, and Lightcast, a labor market data and analytics company. It's a really, really great report, 50 pages, and if they could come in and maybe do a presentation on the workforce, I think it would be fabulous just to, kind of get our head in that zone as we go forward.
Senator Housley, if I can just ask for some clarification. Workforce is a big word.
Yep.
Right. So as I'm listening to this, I'm hearing two different types of workforce. Are you talking about both for Presbyterian Homes, the workforce that they need, but also then for the business partnership, a broader definition of workforce?
It's broader because it's in every sector
Perfect.
across the state, but we could have them narrow it in, but it still is.
Oh, no,
is-
I think the
yeah.
broader,
Yeah,
the
yeah.
better. No,
Yeah,
I
it's
totally
broad.
agree with you. I just want to make sure that that I understood you were being more inclusive.
Yep.
Okay, perfect. Thank you so much.
Yep.
Any other suggestions? Ms. Schneider?
Thank you, Madam Chair. Excuse me. I want to also agree with the comments regarding the workforce labor shortages. I think it's very much at the crux of a lot that we talk about. I'm thinking about the early days of home and community-based services in Minnesota, when we were just getting started with things like adult foster care. And we were really looking for anything that would be an awareness raiser so that we could begin to build a continuum of home and community-based services. And one of the things that we looked at that time was partnerships with our community colleges. And what we did was we offered individuals who had previously in their life experiences not been able to get a college degree. And we offered them courses that would help them to be a caregiver in the new paradigm of home and community-based services. And as I've said in front of this task force before, I think we're probably going to need to return to some of the things, the clues, the indicators that we learned from those early 90s. Because we cannot afford, obviously, to say, okay, now we built this continuum. Yes, that is true, but it is fraught with issues. And so I'm thinking about things like partnering with community colleges to give some credit-bearing courses on occupations that would be helpful to serve an aging population. That's just one of the places we could look. The other place I think we could look are at seniors who have retired and who some of them would be more than happy to continue their work in their profession, but they would like to have their schedules tailored. They would like to come in at somewhat near the same pay scale as when they retired. They would like to possibly warm up in the winter somewhere and be gone for a few months, but they are willing. I've talked to them, and they would like to do something because we understand as retirees that we still have work to do in this whole field known as aging. So I hope, and I think we will be able to, but I hope, and one more thing. I heard Dr. Gaugler at the Age Friendly Minnesota Conference a couple of weeks ago or a week ago, and I think I know a lot about caregiving and no-cost, low-cost services in this state, but I couldn't write fast enough, Dr. Gaugler, just from what you were talking about. And I feel like we have got to get our arms around these no-cost solutions and begin to realize what a value add they are to our bottom line of aging and respectfully treat them appropriately. So that was a long comment, but again, back to workforce issues. We got to tackle it.
Thank you. Senator Morrison?
I guess I would just, I think, fourth, the ringing the alarm bells about workforce challenges, because I think all three of you brought that up. We have massive workforce shortages, particularly in every aspect of healthcare and long-term care. It's a huge challenge, and I think it has to be among the top three of what we're looking at on the task force, and that we need to come up with some proposed legislation to help our state address it. No cost would be great. We have to be investing in our young people too, but we emergently need people in Minnesota. So figuring out what that might look like, I think, has to be part of our challenge. That's part of the issue with the bottlenecks in our hospitals right now. I mean, we have press homes. Senator Helsley mentioned Presbyterian homes. They have wings that are empty because there's no one there to take care of the long waiting list of people who need a place. Thanks.
Okay. Ms. Foley, did you want to say something?
I'm looking at transportation needs that people with disabilities need, aging populations need transportation, not only to medical appointments, but to grocery stores and for shopping and things like that. So I think that's a big need, especially in the rural areas. In the cities, you get the metro buses, but that's a big shortage in the rural areas. They don't have the metro, what's it called?
Metro mobility.
Metro mobilities. And so getting rides to and from appointments, to and from grocery stores and things like that is a big issue. And I know that there are some communities that do it better than others, and if we could highlight the ones that do it well and get some of those, get pilot programs in outstate areas, that would be great.
Thank you. We have a great deal of work ahead of us. Sometimes it seems overwhelming. I'll wake up at 3 o'clock in the morning. So from you today, I heard we cannot abandon the health above our shoulders, that we need to make sure that we are considering health holistically and embedding those needs into all of our work that we're doing. We've talked about housing today, mentioning that housing is an important issue, mentioning transportation, mentioning that workforce, in the broad scope, as we are an aging population, we need to make sure that we have as many work opportunities as we can for those who are capable and willing and wanting to continue their economic life, as well as finding the workers that we need to help care for those. I'm reminded of a conversation that I had with individuals at the Council on Disabilities who said to me, well, Representative, if you live long enough, you will age into disability. So we need to make sure that all of our systems are structured to continue through that lifespan. So what do livable communities actually look like, whether it's in greater Minnesota? And as a suburban legislator, I think about the transportation needs. That last mile is almost impossible. There is food insecurity in every part of our state, affordable housing all across our state, whether you're in the metro or in greater Minnesota, it's an issue. And then how do we do this work from the very beginning of the life cycle so that we know that the systems and structures that we're building will serve us through the end of our days? And I think that's an important piece of work. So what communities, as you said earlier, are doing good work? Who can we bring in to talk to or to have them explain to us what's working well in other parts of our country that we could adapt here? We need to think about the research that's out there and what of that research would inform the work that we need to do. So if individuals have white papers or research that they want us to be aware of, I would ask for those submissions so that we have that to read and to have that available to us. It is a lot of work. So to the public, I would say to you, on the Legislative Coordinating Commission, webpage for the Legislative Task Force on Aging, there is a space for you to write in and to let us know what's important to you, what's your experience, what have you seen, what do you need if you have that ability to do it. Use your intergenerational connections. Call your grandchild and say, I want you to enter this in the portal for me so that we can hear your story. Talk to your librarians, ask them for help in getting that information to us. I think also in talking with members on this task force, we need to hear from our county agencies, what is happening in the county, and how can we better partner with our counties and our townships to make sure that we're meeting the needs of individuals all across our state. Dr. Gogler, did you want to jump in? I love your body language, yes.
No, yeah, I mean, you really pick up on that, don't you? I have to be
Yeah.
careful. So I didn't realize the chair was a mediator, right? Your professional expertise, so I have to watch my facial expressions and body gestures and all those things. So, I mean, I agree with everything that's been said. I think all the topics raised are critical, hospitalization, transitions of care, workforce, housing. I guess when I'm ever tasked to write a report, again, this is just me, I do like having a framework
Yes,
to kind of inform and flow the rest versus,
Yes.
Okay, we're going to talk about this issue, then it becomes kind of a laundry list.
that's correct.
And again, I know I'm a broken record. I do think if there's a framework that can help organize all of these topics, I do think it's social determinants of health. I mean, when you talk about issues of workforce, housing, transitions of care, they all flow through this framework in different ways. And using that as a basis then to inform, okay, what are our actions going to be, legislative or otherwise, I think would be very helpful in terms of a writing approach. And it'll make it a little bit less overwhelming too, I think.
I think that's a great suggestion, and for the reader, it's a comprehensive story that they can follow. So I think that's really an important way. So maybe we should, if you have comments about that, whether that would be an appropriate thing, please let Mr. George know. I, for one, am supportive of that approach. Is anyone from the public interested in testifying today? I want to make sure that those individuals in the room who've traveled today, if they have a comment that they would like to, if you'll please come to the, thank you so much to the Minnesota Department of Health. If you'd come forward and, that's all right. Yeah.
I just meant that I didn't know I'd have to come up here. But
That's right. What I would like for you to do is to state your name, and maybe if you don't mind, just give us your zip code so we have an idea of where you're from in the state, and then if you'll keep your comments brief. Thank you.
my name is Jamie Greshwak, and I live in Marina on St. Croix, 55047. Senator Housley is our senator. I'm a Six Sigma black belt. And for 3M, retired 30 years, and there's probably half the people in the room are going to go, Six Sigma, oh, yuck, right? But I had the human side of it.
Yeah.
They brought me in, I worked in human resources. There are some really simple, good tools. I know the state has their own preferred prioritization methods and tools, but Six Sigma has some really good, simple tools that could help us frame what we're doing and where can we make the greatest impact for the investments. We as constituents, I may be overspeaking, but the people that I talk with who are advocating, we believe we have the smartest people in the country working on these things, even the fact that the task force exists. We just seem to have trouble executing, and we have trouble getting people to reach out and access is what I hear. And some of these tools, there's a tool called C&E Matrix. I don't know if anybody has ever used that, but it literally lists priorities like housing, affordability, fall prevention. My mother fell twice in an assisted living home and we couldn't recover from that. These things that you can prioritize, food insecurity, and you can then simply say, what are we doing? What are we as a task force proposing that we invest in? And you can score against those things. And it becomes a really simple overriding tool to use so that everybody knows what we're working on. And also, there can even be categories of innovation. So what are we doing innovatively, Minnesota? And what items are we doing against those goals? So I guess the reason I jumped up was to simply say that there's some very simple organizational tools that we could organize all the great work and brain power of this state and then come to the public and say, these are the things. And to your point, Madam Chair, the ability to work on things between now and January. My passion when I worked on Six Sigma was always low-hanging fruit. I heard 10 things today that we could do right away. And it would cost no money to do that. It would simply be an organizing activity, and there's a couple, legislative bills that come to mind that we could make a huge difference as we go on the things that we already know. In fact, one of my favorite books is Why Don't We Do What We Know, right? Because we know in Minnesota. I'm sincere about that. So that's all.
Thank you very much. Your comments are greatly appreciated, and you bring a lot of good thought to the committee room, so thank you for being here today. Our next meeting I'm sorry, please. Thank you very much. I didn't see that. Thank you. Please come forward. So if I could ask, who is the next person who wanted to speak? Is there another person? Okay, thank you. If you would please state your name for the record, and then again, if you would just kind of give us a general idea of where you live, and then state your comments.
Thank you, Madam Chair. My name is George Schapoister. I'm a geriatrician from the St. Cloud area. I've been retired from clinical practice for a couple years. I've been involved, I co-chair the age-friendly Minnesota St. Cloud group, and one of the things that's become clear in our work is that it is going to be, I think, best for the community economically and for individuals if we can figure out how to help and provide resources to people to age in place and age in community. And the difference there being age in community provides the environmental things that we were talking about with social determinants of health to make it a safe and high-quality place to live. In order to do that from the medical perspective, I think we need to figure out how to put less emphasis on long-term care structures and more emphasis on long-term care at home, which is where most of the people are going to living. And so the comment and the suggestion I'm making in terms of where you go forward is getting back to a comment I heard Dr. Gaugler make, I think, last time. I think we need to figure out, and this won't be easy, figure out how to change how we finance, I'm going to call it long-term care, but how do we finance health care for the older adults, which I recognize is a Medicare thing, and that's not a state issue. So, but I think we need to figure out in Minnesota how to make that simple and provide good continuity of care.
May I ask you a question, please?
Yes.
So when you talk about how we finance, earlier we heard the Department of Health talk about longevity, right? So would you be open to the idea of how do we finance healthcare for longevity? So not necessarily only focusing on financing for our
Illness.
For illness, but financing long healthcare for the entire healthy life cycle.
Absolutely. I think it got stated here at some point, at least it's a belief of mine, that only 30% of what I used to do in healthcare improved the quality of life for the older adults. 70% is provided out in the community, and I agree. That's financing needs to start to address those things. But it was interesting, this guide thing that Dr. Gaugler mentioned, they are starting to talk about financing the caregiver, even if the caregiver isn't a Medicare recipient. So that's one example of where I think it could go.
All right, thank you very much. Is there anything else you'd like, Krista?
No, thank you for your time.
I appreciate your testimony. Thank you so much. Anyone else in the public? It's hard to see from this seat, so don't be bashful. Okay. Well, thank you. I think that concludes our work for today. As I said, the Legislative Coordinating Commission portal is open for suggestions, comments, life experience. We want to hear from you. I'll say that again. We want to hear from you, the public. You're the most important part of this equation. And then our next meeting will be in November, the 14th of November, and we'll be meeting in this room at 10 a.m. And with that, our meeting is adjourned. Thank you.